provide greater evidence or proof that these are evidence-based pathways. I mean, is the worry here that these insurance companies are determining these pathways for economic reasons or to save possible revenue at the expense of patients? Is that the belief?
Yes, they incentivize doctors to use the pathway, $350 a month to use the pathway. And consumers need to know that that's not the reason, and no one's saying that's bad. I believe in incentives and I want cost reduction. But when you're engaged in that, then I think the consumer should have the assurance that it was a full breadth of scientific research that actually developed that pathway.
But then shouldn't the law be not to provide greater transparency? Shouldn't the law be to outlaw any kind of incentives or financial reward for doctors?
Oh, if we did that, the medical world would come to a stop. So, I mean you can try to take that one on.
I'd love to hear from the doctor actually specifically on the nature of how can we bring more transparency to this, and whether or not are these decisions being made for financial reasons and not fact-based evidence based on medical decisions.
So the pathways are developed based on medical evidence. So some of the examples I cited earlier, there are no treatment alternatives. Those are the treatments, and despite the fact that they save lives, they are not in use. And so the $350 a month hopefully incentivizes physicians to use evidence-based treatments. There are other situations where there are equivalent treatments that range in cost, Baez was given an example, a 20-fold difference in cost. And in that situation, having gone through the evidence, cost does come into play. I want to put the $350 a month in context, though, because most of the revenue for oncology practices today in the United States comes from the profit margin on the drug. So if we're to encourage practices to become more value conscious, we have to make up that revenue. So for $65,000 for 3 months of lung cancer treatment, that's approximately $6,500 revenue to the practice for those 3 months. So in that context, $350 a month for following a pathway is a pretty marginal incentive.
So you're saying, though, there is we would hope no doctor would engage in this. I know my brother's a vascular surgeon, and I've talked to him at length of this issue, that oncologists are paid by percentage of what the drug costs that they're prescribing.
Right.
Doctor, would you like to?
The idea.
Let's let the doctor answer
Sorry.
that.
Yes.
Well, in reality, that's something that's also being discussed at a larger level, national level. But what really that occurs for is that's a lot of the overhead, the nursing, the administration of the drug. Those things are minimally reimbursed. So a lot of times the drugs, and there has been some disconnect, but a lot of the toxicities and things that occur around drug administration. So it's a little more complex.
But do you think there's this is getting into a bigger subject. I don't want to take too much time. But is it?
That's a.
Well,
is there some type of ability for doctors on these pathways to say, I don't think this pathway is the correct choice under this plan, I'm not going to follow this pathway, I think this pathway is a better choice? Do any of these insurance plans currently not allow that? Or there's a $350 incentive. I don't think that's,
And not currently. Our problem with the pathways approach is that there's a couple of potential concerns in the future. But the reality is, yes, the pathways are voluntary, but we would like to know why that pathway was chosen over another. And at least then if we are using that pathway, we then have a better understanding. Is this a cost-effective? It's very straightforward to say this is a cost-saving process. We would just like to know that. That has not really been forthcoming. So really for physicians to know the basis of this, and what has been disclosed, yes, we also understand the literature behind a lot of the pathways, but really the question comes up, who was on the committee to decide this? Was it pharmacy? Was it physicians? Was it a combination? The pathways that currently are out there really is a disclosure about everyone who was involved in the pathways development, and that is very straightforward. We don't see that as a very big issue in terms of not disclosing that, but it hasn't been forthcoming.
And could I just want to respond to your earlier question because I conferred with our sponsor, and we would be very happy to include the same statute to everyone who develops pathways. So to Ms. Olson, to Mr. DeBobne, transparency for all, we're for it.
I mean, my final question would be, I do think there needs to be a level of transparency that's greater. I don't know how to accomplish that. This bill's one way. Doctor, I mean, you obviously kind of straddle the fence on this issue. You're providing care at my alma mater and to a VA that's very near and dear to my heart. You're also employed by the insurance companies. How, as a doctor, can you reconcile this? How can we get greater transparency without, at the same time, losing any type of incentive or any type of momentum that is leading to greater pathways that give greater opportunities to people to obviously get better outcomes when they have cancer?
So we support the goals of transparency, and again, our program to date is the most transparent one out there. So we publish, www.cancercarequalityprogram.com. You can download every pathway. You can send an email to cancer.quality@anthem.com and get, about probably 500 pages of evidence summaries at this point that detail all of the evidence, all the references, and the cost of the therapies, and you can see for yourself why, which therapies are on pathway and which ones aren't. So there's tremendous. The specific names of the external advisors are currently not provided publicly on the website. We're in the process of listing their conflicts of interest, which actually, in contrast to many of these other organizations, are none. So they don't have hundreds of thousands of dollars in money from different competing organizations, as some of the other groups do. But we support the transparency, and we would just suggest that drug distributors and other organizations that do it
I think I've
should
already
have to
stated
provide
that I'd be happy taking an amendment going forward to apply it to everyone. who
I would
develops
appreciate
pathways.
that. And would that somewhat change your opposition to this bill? And I will ask you from industry as well, can you just state, are these decisions ever made, are any of these decisions on pathways ever made for financial benefit and not, and this not to the doctor, she's made that clear, but to industry, is any of these decisions ever made for financial benefit to the shareholders or to the company and not at the...
So I can speak it since I work at Anthem. The decisions are made to achieve optimal care. I mean, that's really, so cost is only, similar to our formulary processes and the other processes that we have in place, cost is only considered after all clinical decisions, clinical
But then why
factors.
the $350? That seems like such a small amount anyway to give doctors. What is the $350 incentive really accomplishing? What is the real goal of that? Because it does optics appear bad on that.
Well, so the goal is basically if on average, so an oncology practice has 7 FTEs on average per physician. So if on average oncologists were to shift their prescribing behavior to be more value conscious, that would decrease the revenue to the practice and they wouldn't be able to continue to operate and stay in business. So our goal with the $350 a month was to provide additional revenue for care coordination and treatment planning that wasn't tied to the margin on the drug, so that as practices adopted pathways and shifted towards a more value-focused care, that they would still be able to stay in business.
That's fair. Thank you.
Mm-hmm.
Any other questions?
Well, I didn't hear from industry, though, on the question about...
I'm
decision-making.
sorry, Assembly Member.
So, I mean, we've heard
You're in
basically
favor of the
today
bill
that
now?
there is a thought that some of your decisions being made on these best practices or the best pathways going forward are made with financial decisions in mind. Is that ever the case?
Well, as Dr. Malin suggested, the only time cost would factor into the equation is if you had 2 treatments that, according to the evidence, had the exact same outcome, then cost would come into play at that point. But before the evidence is reviewed, then that is more of a, not an afterthought, that's probably the wrong term, but it only comes down to when you have 2 equivalent treatments that vary in cost.
I'm sorry, Mr. Gomez.
Ms. Bonilla, thank you for bringing this bill forward. It's, I know it's complicated and there's might be some unanswered questions, but the chair has informed me that there's been a lot of progress made. I believe that we have a legislative process. It's not one committee. It kind of works through, and sometimes bills are made better and sometimes they're made worse. But, I'm going to hold final judgment down the road, but I'm going to support your bill today. I think a lot of people in the legislature and probably in this room have lost loved ones to cancer, and it's something that people have to deal with, but it's also something that we have to figure out how to address to make sure that patients are getting the best treatment. And of course, cost is always associated with it. I lost my dad to pancreatic cancer. It wasn't based on necessarily any kind of lack of treatment, but it was a lack of access, right? Too long. It took too long to have him actually see an oncologist. It took too long to actually get just the basic test done. So I appreciate your bringing this bill forward. I know it's not easy, but as it works through the legislative process, after if it gets out of approps, let's have another discussion about how I'm going to vote on the floor. Thank you so much.
Anyone else? I have a couple of things I'd like to before you close. First of all, exact same outcomes I heard from the side of the table, and costs, and then that's when costs would come in. So, is that ever the exact same outcomes ever debated by clinicians? I know in my world and practice of dentistry, sometimes you might say you'd have the exact same outcome, but as a clinician, I would potentially dispute that. So how is that handled when there is a question about what's considered the exact same outcome?
So I think this is an issue that happens not only at kind of in groups that are developing pathways, but also national guidelines. So there's a number of different ways that gets looked at. But that's why we rely on external expert advisors who help interpret the data. That's why the data evidence summaries are available, and it's based on looking at clinical data and then also countering it with what do the guidelines say? Do the guidelines treat these as equivalent treatments? If you look at NCCN guidelines, as was mentioned, for non-small cell lung cancer, just for the specific subset of population that doesn't have one of the new mutations, NCCN lists 65 different treatments as equivalent treatment options. And they haven't rated them as one better than the other. I mean, many oncologists might select from between them and have preferences. But again, if the national guidelines haven't said this is a better treatment than that one, and then you have experts look at the actual studies and compare the outcomes in terms of what was the survival, what was the progression-free survival, what are the toxicities, you start to come to consensus on treatments that are equivalent. And in our program, we err on including as many as multiple treatments that would offer physicians and their patients multiple choices.
Well, I would guess. Appreciate where you're coming from on that, but I would guess that exact same outcomes that may not be the right description. Exact same, so I'm curious what Dr. Murda has to say.
I actually really appreciate that question because as you relate to other specialties, it's the person in front of you that actually will behave differently, and so I think that where we really get to is there are different side effects with similar outcomes, and so the ability to choose between various choices is still critical. But I do think that the guidelines, if they're, or actually pathways, if they're based on certain criteria, we would like to know that so that as we decide to be on or off pathway, we can equally make good decisions. I think that, as mentioned, NCCN, which is the national organization, completely transparent. We know the decisions that go into that. They have recently instituted 5 levels of evidence that does include cost as a deciding factor, but they don't limit to one particular treatment. They actually do provide that information on cost so that we then can make decisions informed with our patients. In this case, where the payers are now making the decision to have a recommended pathway as opposed to the physician with the patient deciding, that's really our problem.
Okay. And then a question for you, Dr. Murda. If the ultimate goal is for us to actually treat cancer and get the best possible outcomes for everyone, why are some of these pathways considered intellectual property and not shared with the greater medical community? I fail to understand why that might happen.
I think there is really the decision process within the pathway, and I think there the transparency is a similar problem. We would totally agree with that as well. So that's really, I think, the crux of this bill is really to share that information of why a pathway was decided on, because, as stated, there are multiple decision options and treatments for lung cancer, and they are given equal weight. But actually, in reality, that's a misstatement. They're not given equal weight anymore because they are rated on efficacy, safety, which is another version of toxicity, and cost and other factors, so that and convenience for the patient as well. So all these factors really do come in, that there is we attempt to personalize medicine, and that's also a driver now of oncology care in general. So I do think that being transparent is really the crux of this bill. I don't think that we would mind if the plan actually admitted that it was all costs that went into this with effectiveness, but we would just like to be able to talk to our patient about that, because that is an important topic.
So you in the future aren't looking to keep this closed as intellectual property. Is that my understanding?
Yes.
Okay. Thank you. Okay. We'll bring it back. Would you like to close, Ms. Bonilla?
Yes, I would. To the opponents, if all the information is already available, as they have stated, I'm not sure why this bill is a problem for them. And the one issue that they raised was the unequal application, and I've already stated that moving forward, I'm happy to apply this to anyone who develops a pathway, the same transparency standards. This is about the patient-doctor relationship, and the availability of information. With that, I ask for your aye vote.
Mr. Chair, question of clarification.
Sure.
I just want to make sure through the chair. So is that an amendment being taken today in Health Committee, or will that be at the next committee?
It can't be taken today, but I will take it in the next committee.
Okay. Thank you.
Yeah, and I was going to clarify that. It can't be taken. It's actually a pretty complicated amendment when you start working through that one.
Oh,
so
this whole bill
I wouldn't.
is.
Yeah, I would not. I wouldn't accept that even if you tried to push it on me. So good luck
We
on
won't
that
do
one.
it orally, yeah.
Thank you. So, and while I appreciate, and we have had numerous conversations, Ms. Bonilla, about the bill and your attempts to amend the bill pursuant to some of the concerns that have been raised by the other interesting parties and the committee as well. The definition of clinical care pathways appears to remain unclear without an identified standard legal or clinical definition, and that was part of the challenge that our staff and the committees had in analyzing the bill. Now, to keep the conversation going, because this is actually pretty complicated, and it got even more so today, I'm prepared to support the bill now, with your assurance, which you gave me, that moving forward you would continue to work with us on
Absolutely.
this, and that includes all stakeholders, the consumer groups, the health plans, everyone, to address the remaining concerns in this bill.
Absolutely.
Based on what you want to do there, it's coming back. Okay,
Yeah.
if it leaves here today, it's coming
Absolutely.
back again at some point. This is complicated, and I at one point yesterday I sat down in my office and said, I'm lost. And so, but I think you bring up the conversation here is really interesting and important. It also brings up something that I will get on a little bit of a soapbox on in the future on really complicated issues like this. I would prefer that we find ways to actually debate, and rather than debating them, actually looking for hearings and things that we can actually put this out on the table, bring everybody together to discuss the problem we're trying to solve, and look for solutions prior to moving bills forward. And that would include potentially the analysis that we need to actually do a clear analysis on that. Now, I realize that doesn't help us at this point, but that's kind of the vision I have going forward on these really complicated issues. And so I appreciate that, and we will churn through this one for a while. So. With that, I would like the motion. There is a motion and a second. Was there? It's been a while, so I'm sorry. There was a motion. There is a motion. And Ms. Burke seconds. So I'll ask the secretary to call a roll, please. The motion is due pass to as amended to appropriations.
Thank you.
Wood?
Aye.
Wood, aye. Mainshine? Bonilla?
Aye.
Bonilla, aye. Burke? Burke, aye. Campos? Campos, aye. Chu? Tabobny? Gomez? Hernandez? Lackey? Nazarian? Holston? Patterson? Patterson, no. Ridley Thomas? Rodriguez? Santiago? Steinnorth? Thurmond? Aye. Thurmond, aye. Waldron?
So the vote is currently 5-1. We're going to leave that open. Our beautiful quorum disappeared, vaporized before our eyes. So you have another bill before us, Ms. Bonilla.
I do. It's turning into a long afternoon. Thank you so much for your indulgence, Mr. Chair and members. AB 2764 ensures breast cancer is detected earlier and requires less intensive cancer treatments. This bill requires health plans, and they're going to be back up here in a minute, I don't know why they left, to cover digital breast tomosynthesis, known as DPT. It's a new technology that is used concurrently with 2D mammography. Over 200,000 women in the U.S. are diagnosed with breast cancer every year. It is much easier to treat if it is detected early. Mammograms are the best method of detecting breast cancer. For a typical mammogram, images are taken at the front and side of the breast. However, from those viewpoints, tissue can overlap, and that decreases the visibility of tumors and the likelihood of false positive results. Between 15 and 30% of cancers are not detected with a standard 2D mammogram. The Federal Drug Administration approved the use of DBT in 2011. It is a 3D imaging technology where images are taken from all angles. This technique reduces this tissue overlap and false positives. Numerous studies of over 500,000 women have shown when DBT is used, in addition to 2D, the rate of cancer detection increases by 27%. And the rate of false positive decreases by 15%. Medi-Cal and Medicare began to cover DBT in 2015, and current law requires health plans to cover all screening and diagnostics mammography procedures. However, health plans are not covering DBT for their patients because they claim it is investigational. AB 2764 addresses this problem by requiring health plans to provide coverage for DBT. It only costs $56 a visit. It's a very small amount compared to someone getting a false positive and having to come back in for additional screening, which could be an average of $1,025. With me today, I have Dr. Ray from the University of California, San Francisco School of Medicine.
Good afternoon. My name is Dr. Kimberly Ray. I'm a breast imaging radiologist, and I'm on the faculty at the University of California, San Francisco. I'm here also representing the California Radiological Society and the American College of Radiology. And I appreciate having the opportunity to speak with you this afternoon about digital breast tomosynthesis, so-called 3D mammography. So as a radiologist, I really believe that a picture is worth 1,000 words, and so I wanted to start off by just showing you a case example that illustrates, I think, the value of this particular technology. So here I am just showing you images from a screening mammogram in an asymptomatic woman who was ultimately diagnosed with breast cancer. On the regular 2D mammogram shown here to the right, you can barely appreciate an underlying abnormality. On the regular 2D mammogram, most radiologists would likely interpret the study as normal, negative, and ask the patient to return for routine screening in another year. In this case, however, the patient also happened to have a tomosynthesis exam on the very same day, and on that 3D study, there was in fact a very striking abnormality, a dense spiculated mass that's shown here on the lower right. And this is her cancer that was almost invisible at 2D mammography, but was diagnosed at tomosynthesis. And this is a very obvious finding at 3D that no radiologist is going to miss. So for this particular patient, having access to tomosynthesis gave her the benefit of an earlier diagnosis. This means she is more likely to be cured of her disease. She is also less likely to require aggressive treatment such as chemotherapy and more extensive surgery. Ultimately, it means that she is less likely to die from her disease. And so tomosynthesis is, in fact, potentially life-saving technology. Now, what exactly is tomosynthesis? Why is it particularly effective? Without getting into technical details, I'll just offer an analogy. Reading a conventional 2D mammogram is like trying to read a book by holding up the entire volume up to the light and trying to guess at the content that's hidden deep within. Having tomosynthesis, on the other hand, is like being able to finally turn the pages of that book and see clearly the words that are written on the page. In clinical terms, this means we're better able to detect cancer when it's present. And in the majority of women who will, in fact, be disease-free, this means fewer false alarms, less unnecessary additional testing. Tomosynthesis has now been studied in almost 500,000 women. All of the studies have been remarkably consistent in showing that this technology reduces the false positive callback rate on the order of 15 to 30%. It also increases cancer detection by approximately 30 to 40%. Based on this scientific evidence, the leading experts in breast imaging, who are represented by the American College of Radiology and Society of Breast Imaging, have concluded that tomosynthesis should no longer be considered to be merely investigational and should be available for use in routine clinical practice. Radiologists in the community have already embraced tomosynthesis even when reimbursement has been lacking, simply because it's clearly a superior technology. Ultimately, we want to be able to offer the best to our patients. Guaranteeing reimbursement will simply ensure that there's a level playing field for all women and that we grant access to life-saving technology regardless of a woman's ability to pay. Thank you.
Thank you very much.
Very briefly, Mr. Chairman, members, Bob Ackerman with the California Radiological Society, the sponsor of legislation. A very important technology, very important to women in breast cancer screening, early detection, reductions in callbacks, et cetera, all benefit. Just as a point of reference, Department of Managed Healthcare has an independent medical review process where a patient of a plan can appeal to DMHC when a service is denied as investigational or not scientifically proven. Just looking today at the DMHC website, there are 129 IMRs that have been filed for failure to cover DBT by a plan. 117 of those overturned the plan decision and mandated coverage. So I think the tide has clearly turned in terms of technology. 90% of the mammography units now being replaced in California are being replaced with DBT. So awareness is there. I think once radiologists have used the technology, they're not going to go back. So we ask for your support.
Thank you very much. Other witnesses in support? Seeing none, I will ask for witnesses in opposition. Please come forward.
They sent the women for this one.
Good afternoon, Chair and members of the committee. I'm Jennifer Alley with the California Association of Health Plans. Our 48 public and private organizations collectively provide a mammogram screening as required as an essential health benefit for women. As we go on and we look at mandates, we've given you the figure of upwards of $400 million in costs. The cost analysis for this mandate is not available yet. CHBRP, as you know, did send out a letter kind of specifying some of who doesn't support the use of this bill or this treatment. Specifically, the United States Preventative Task Force, which was used to send the benchmark for screenings linked screening requirements in the Affordable Care Act to that task force. The American Academy of Family Physicians, the American Congress of Obstetrics and Gynecology, the National Comprehensive Cancer Network, and the American Cancer Society do not support the use of tomosynthesis as a breast cancer screening tool. It's for these reasons that our member, in addition to the unknown cost of a new mandate, it is against the clinical guidelines at this point to use this tool. And for those reasons, we strongly oppose. Thank you.
Okay, thank you.
Stephanie Watkins on behalf of the Association of California Life Insurance Companies. I'll just echo the comments of my colleague. It is a long hearing day and leave it at that. We remain opposed to the bill.
Thank you. Others in opposition?
Yeah, John Winger on behalf of America's Health Insurance Plans, also opposed.
Okay, thank you.
Sherry McHugh representing the California Chamber of Commerce, also opposed.
Okay, thank you. Any comments or questions from the committee? Seeing none. Actually, is there anybody? I'm going to ask someone from the opposition to come back. I have a question. Sorry, I should have thought of that. You're getting a lot of exercise on the aisle today, so appreciate the list of people who don't support this, and I know, and as part of the background, one of the points that was raised by the plans is still considered investigational. Is that a fair characterization?
Some of our members do still consider it investigational. Some of them don't consider it best practice. And there's also additional concerns with a new mandate where only 20 to 25% of the radiologists in the state have the equipment to perform the test. And so that causes a concern about the ability for us to implement the mandate as well.
I would imagine it's a pretty expensive piece of equipment to actually do the diagnosis. I guess I would question if it's covered under Medicare and it's covered for our Medi-Cal patients here in California, then why it would be considered investigational at that point. I guess I'm trying to make that one correlate in my mind. And I guess I would ask, the photographs are pretty compelling. When you're looking at this and deciding, how to gauge your support or opposition, what is the cost of a misdiagnosis versus the cost of $56 for the test? What is the cost of a misdiagnosis?
Well, I don't think it's just the risk of the cost of diagnosis. I think you need to look at the entire scope of services that would be provided prior to the onset of breast cancer treatment. And it is my understanding that it would be when something is viewed during the mammogram prior to scheduling a needle biopsy or any other course of treatment, that the woman would go and receive an ultrasound. And so that is kind of what is a service that would be needed to be completed prior to surgery. And so why would we add an additional screening at the front end if prior to providing care you're going to have to do additional tests after that? So I think you need to look at the entire steps that go into prior to treatment for breast cancer actually starting.
Okay, you look like you had an answer for that as well, or thought anyway.
Sure. So overall, there are several benefits to tomosynthesis. Number one is we want to only minimize the number of unnecessary callbacks. So we really want to focus on calling back those women that truly need additional testing, thereby minimizing one of the harms of screening mammography, which is often cited by the U.S. Preventative Services Task Force. So we want to reduce unnecessary callbacks. DBT has been shown in numerous studies to reduce the false positive callback rate on the order of 15 to 30%. So that's one of the benefits of tomosynthesis. That in and of itself will result in substantial cost savings. Secondly, the second major benefit of tomosynthesis is the improvement in cancer detection. So when there is a true positive finding, we are better able to detect that true positive finding and thereby reduce delays in diagnosis. And what this means is that because we're able to clearly identify upfront those patients that truly need additional testing, we are not spending excess money doing unnecessary biopsies and expensive tests such as MRI and even ultrasound on women that don't need the additional testing.
Okay, thank you. Any other questions, comments? Would you like to close, Ms. Bonilla?
Well, thank you very much. I would ask for your support on this bill. I think that this is a very critical issue to women and their families in the state of California. As you pointed out, that it is not investigational anymore. I believe there is a tremendous cost savings and a tremendous amount of peace of mind for women who currently may be called back for a secondary test and then find out no, it isn't breast cancer after all. I would ask for your aye vote. I think this is a very important. The word mandate was used. It does mandate payment, but of course, if that equipment's not available, then the billing would never happen. But as we make a transition, more and more radiologists are moving in this direction. It is definitely where we are today. Thanks.
Well, thank you for bringing the bill forward. I think of my own profession and the advances in imaging, specifically related to the placement of dental implants, and now what is considered the standard of care by most oral surgeons is use of tomography, which actually helps you in the exact precise placement of the fixtures, leading to a lot less bad outcomes down the line. So appreciate you bringing this forward for us. I'm going to be supporting the bill, and I will ask the Madam Secretary to call the roll. And the motion is due pass to appropriations.
Wood?
Aye.
Wood, aye. Mainshine? Bonilla? Bonilla, aye. Burke? Burke, aye. Campos? Campos, aye. Chu? Tababne? Aye. Tababne, aye. Gomez? Gomez, aye. Hernandez? Lackey? Not voting. Lackey, not voting. Nazarian? Olson? Patterson? Ridley Thomas? Rodriguez? Santiago? Steinnorth? Thurmond? Waldron?
6 6-0 at this point. We'll leave it open, and hopefully we'll get a quorum back at some point. We have 14 bills to go, folks, if anybody's keeping track out there. Mr. Gordon. I heard a phrase earlier, I'll be brief, and that was almost music to my ears. So